Hello, today we are going to be discussing neonatal cholestasis. John Cook wrote in 1769, jaundice, many infants are affected by this disease, some are even born with it, but it's rarely mentioned, though a great many die of it. What was true in 1769 is true even today. What is neonatal cholestasis? Conjugated bilirubin of greater than 1 if the total bilirubin is less than 5, and conjugated bilirubin of more than 20% if the total bilirubin is more than 5 is neonatal cholestasis. Any baby who has jaundice beyond 2 weeks needs to be investigated to rule out neonatal cholestasis. Now, what causes neonatal cholestasis? Well, there could be a problem within the liver or there could be a problem outside the liver. Outside the liver, there could either be biliary atresia or there could be a choledochal cyst. Within the liver, there could either be a bile duct injury which manifests itself with a paucity of intrahepatic bile ducts, which is very different to biliary atresia, or there is an injury to the hepatocytes which could be because of a metabolic problem, it could be because of a viral infection, or it could be idiopathic. This is data from India in 2000. In this paper that was published in Indian Pediatrics, data was collected from 8 centers across the country, and as you will notice, the vast majority of this was neonatal hepatitis. Now, what was the precise etiology of neonatal hepatitis wasn't very well defined, and a large variety of these babies were labeled as idiopathic because we didn't really have the diagnostic tools at that point in time. The second commonest was biliary atresia. This is data from our hospital. This is data for 4,603 individuals, babies and children who were referred to us over an extended period of time with hepatobiliary disorders, and you will notice that 813 out of these 2,351 were because of neonatal cholestasis. And the conditions which presented as neonatal cholestasis was quite diverse. We had neonatal hepatitis, extrahepatic biliary atresia was very common. We had some infections, choledochal cysts, paucity of intrahepatic bile ducts, metabolic problems, and multifactorial problems as well. And then we had a chunk of patients where we didn't really have any diagnosis other than the fact that they had cholestasis, and we call this the indeterminate group. So let me walk you through a few case scenarios. Here is a baby, 62-day-old girl, born with jaundice from day 3, stools were sometimes pale, urine was dark. Her birth weight was 2.4 kilos, so she was born small and she wasn't really thriving. At 2 months, her weight was only 2.7. She had jaundice, hepatomegaly and splenomegaly. She was investigated, and what we see here is conjugated bilirubin, all the enzymes are raised. An ultrasound had been done outside which showed a small gallbladder. Torch CMV IgM was positive. Her thyroid profile was normal, and we tend to do a thyroid profile not just for babies with indirect hyperbilirubinemia but also with cholestasis because thyroxine has a role to play in bile flow. A HIDA was done which showed no excretion, and a liver biopsy was then ordered in our center. Here is a gallbladder, small contracted gallbladder on ultrasound, and here is a HIDA that shows no excretion. Now, it's important to realize that when a HIDA excretes, it helps rule out obstruction, but when a HIDA does not excrete, it's not very helpful. This could be obstruction, or this could be because of severe cholestasis that one sees in babies with neonatal hepatitis. And I personally believe, and in our unit, we don't tend to use HIDAs very often because we believe that we end up wasting a lot of time, 3 to 5 days of priming with phenobarbital and then getting this test done, and if it doesn't excrete, it doesn't really make us any wiser. Of course, if it excretes, it helps rule out obstruction. But then by looking at the stool itself, we can get a fair idea whether there is obstruction or not, because if there is obstruction, the stools are pale. So we did a biopsy, and you can see here there's cholestasis, there's some giant cell inflammation, and this really is classical idiopathic neonatal hepatitis. We don't quite know what causes it, but we know that it has excellent prognosis. The vast majority, more than 90% of these babies will get better with time. It's only a question of wait and watch. They need nutrition therapy, they need multivitamins, and then they need close follow-up, and the vast majority will be well in 6 months, 9 months to a year. The second case, 82-day-old girl with jaundice from day 7, pale stools, dark urine, so very similar in the presentation. exclusively breastfed. The birth weight was 3.2 kilos and the baby had hepatosplenomegaly. Conjugated bilirubin enzymes are raised, gamma GT alpha was raised, thyroid normal, torch normal, ultrasound small gallbladder, HIDA no excretion. So in many ways very similar to the first case. A liver biopsy was done, and if you notice at the area of the portal tract, there are no intrahepatic bile ducts in this particular portal tract. So this is paucity of intrahepatic bile ducts. Here's another biopsy of a child with a similar condition, and we have the H&E stain that shows paucity, and this is confirmed with the cytokeratin stain which shows bile duct paucity, and one would want to have a biopsy that has at least 7 portal tracts for the histopathologist to be able to make the diagnosis of paucity of intrahepatic bile ducts. This is the same child, much older, and you can see that she has some facial features of Alagille syndrome. Her forehead is broad, her chin is pointed, and this is the same child, much older. You can see that she has pruritus. Her chin is more pointed, her forehead is more broad. She has posterior embryotoxon seen on an ophthalmic exam. She also has a systolic murmur which is suggestive of peripheral pulmonic stenosis, and she has butterfly vertebra. And in the photo is her brother, who has no manifestation of Alagille syndrome. So I have been following this girl for many years, and this is her now in college, and that's her brother, and you'll notice the height difference. Children with Alagilles do not grow very well. She's otherwise well, and her brother of course has no manifestation of Alagille syndrome. Case number 3, 11-day-old boy with a birth weight of 2.9 kilos, second degree consanguinity, jaundice since 7 days of age. There was a history of sibling death, yellow urine and stools, icterus, liver palpable 4 centimeters, spleen 2 centimeters. All investigations were normal because of a history of sibling death. A bone marrow exam was done which was normal. We did a liver biopsy, and that showed progressive familial intrahepatic cholestasis. And we know that there are 3 different types of PFIC, and with a special immunostain we can actually make this diagnosis, and of course we now know the genetic basis of this entity. There are 3 types: PFIC1, PFIC2, PFIC3. In PFIC1 and 2, the gamma GT is normal. So if any baby has a normal gamma GT, then there are only a limited number of conditions that one has to rule out: PFIC1, PFIC2, and of course an inherited group of disorders of bile acid metabolism. In PFIC3, the gamma GT is increased, but otherwise the manifestation is very similar. If the child presents earlier and one can manage cholestasis with medication, that's wonderful. If that doesn't work, then a diversion procedure can be recommended, and this could be a diversion which could be external, or this could be an internal diversion. And in an external diversion, we reported for the first time in India and second time in the world using the appendix and the appendicular stump to produce external diversion. But in the case that I just showed to you, this was not possible. We had a sibling death. This child rapidly developed acute on chronic liver disease. He had an acute exacerbation on underlying chronic liver disease, decompensated, and then required a liver transplant, and this is him after a successful liver transplant. Next case, a 36-day-old girl with jaundice from day 9. Stools were pale, urine dark, birth weight of 3.1, thriving 3.9, with jaundice, hepatomegaly, and a spleen which was just palpable. Dark urine, pale stools, neonatal cholestasis with conjugated hyperbilirubinemia which was quite pronounced, 4.2 out of 7, raised enzymes, raised gamma GT, raised alkaline phosphatase, no gallbladder seen on an ultrasound. HIDA showed no excretion. We went on and did a liver biopsy, and here you can see cholestasis and bile ductal proliferation. So this baby has biliary atresia, and on CK7 stain one can see bile ductal proliferation. Now if this condition is diagnosed early and babies are subjected to a Kasai's portoenterostomy at a young age, the jaundice clears and they do well, as happened in this individual's case. For this operation, which really is technically a demanding operation where one really has to dissect at the porta and then fashion an anastomosis, hoping that some amount of bile would flow, there are two determinants that define success. And success means clearing of jaundice within 3 months or 3 months after the surgery is done. The first is age at operation. If this surgery is done before the age of 8 weeks, there is an 86% chance of clearance of jaundice, and that drops very dramatically in the course of weeks, and this was published way back in 1989. The other determinant is the skill of the surgeon, and this was published in the Lancet in 2000, and it's been shown, and it was shown based on a study in the UK, that if a surgeon or a center does more than 5 surgeries in a year, their outcomes are much better than in centers that do less than 5 surgeries a year. A couple of years ago, pediatric gastroenterologists from across the country met at Apollo Hospital, Delhi, and created a paper on the management of neonatal cholestasis, and that was then published in Indian Pediatrics and was sent out to the pediatricians across the country. So if I were to summarize the algorithm that we described in that paper, if the child is sick, a septic screen needs to be done, we need to treat for sepsis, galactosemia needs to be excluded. If the septic screen is negative, we need to check for CMV, herpes, ferritin, we should do urinary succinyl acetone to rule out tyrosinemia, we should do GALT to rule out galactosemia. If the child is not sick and the stools are pigmented, we should do an ultrasound, maybe we find a choledochal cyst, we should also rule out metabolic disease, and then the treatment depends on what we find. If the stools are pale, we should do a fasting ultrasound, and this ultrasound should be done after 3-hour fast, and it should be done by an ultrasonologist who has experience in looking at gallbladders in children, and this should be done with a fair degree of patience. So one can find a normal ultrasound, we might want to do a biopsy, it remains optional to make a definite diagnosis. If we see a small gallbladder or an absent gallbladder, we should go ahead and exclude biliary atresia. And if one finds a choledochal cyst, then this child needs to be referred to a surgeon for definitive surgery. So how do we rule out biliary atresia? If the age is less than 6 weeks, we can do after 3 days of priming a HIDA. In our unit, we don't do that. If there's excretion, we might want to do a biopsy to make a definite diagnosis and then specific treatment. If there is no excretion, we need to do a liver biopsy. If the biopsy is inconclusive, we need to do a perioperative cholangiogram. If the biopsy is suggestive of biliary atresia, we need to again plan for perioperative cholangiogram, and a Kasai's portoenterostomy should be offered. If the baby is older than 90 days with ascites, which means there's evidence of decompensation, this child should be referred to a transplant center, because when a Kasai's portoenterostomy is fashioned in babies who have decompensation, which is manifests itself with ascites, they have a very stormy post-operative course. They tend to do not very well, and it's best to let these babies be, because they're going to need a transplant, and sometimes by intervening we hasten the transplant rather than prolong it. And if a baby presents after 120 days, then the option is to refer to a liver transplant center for a primary liver transplant. So we performed 2,312 transplants in adults and children, of which 190 have been in children. Biliary atresia is the commonest indication, and we've done in 74 children, and then a variety of other indications. But I would like to emphasize here that nearly 40% of the transplants that we do in children are before the age of 1 year, and the vast majority of them present with neonatal cholestasis. How successful is liver transplantation? We published our data in very young children weighing less than 7.5 kilos, and we were happy to report 100% survival in this cohort. We have reported our experience with biliary atresia patients, some of which were children who presented late and underwent a primary liver transplant, and excellent results have been reported. So what's changed in the management of neonatal cholestasis in the last few decades? If a baby was born in the 1950s with biliary atresia, there was a 100% chance of dying. But now, if a baby is born with biliary atresia through a portoenterostomy, or a combination of a portoenterostomy and a liver transplant, or in those babies who present at a later age a primary liver transplant, we can say with certainty that 90% of these babies and infants will grow up to be adults, and that I think is very gratifying, and that really shows the progress the field of pediatric hepatology has seen in our country over the last few decades. Thank you.